Hello, am I audible now? Yes, I
Yes,
think
sir.
audible and visible both. So I'm back to the second computer with the disorder. Though a few disorders I've already demonstrated with the demonstration. So one disease that we all know, it's the Quervain Tenosynovitis, that is the disease of the compartment 1. Then there is extensor tendinitis, though all the tendons that can undergo tendinitis. But common, we have told you, the extensor carpi ulnaris and extensor digitorum. Being extensor carpi ulnaris is a long tendinous path at this point, and extensor digitorum is the most strongest tendon at this point. So, in both cases, the ovarian syndrome is very prominent, as well as conditions like spondyloarthropathy can give rise to enthesopathy in these areas as well. Then we have the proximal and distal intersection syndrome that we have already discussed. Then we have the ligament injuries like a scapholunate ligament injury or a lunotriquetral ligament injury. These are the major ligaments, but definitely the all other tendons can undergo, all other ligaments can undergo injury, but these are more common. Then Wartenberg syndrome or chiralgia parasthetica, the name I have not told, but the disease I have already demonstrated. It's the compression of the superficial branch of the radial nerve. That could happen because of a mass at this point, or because of a inflammation at this point, or because of an injury or fracture at this point, and this is known as the Wartenberg syndrome. Then there could be a joint arthritis like a distal radioulnar joint, but it is not the only joint. All other joints at this point may undergo injury. There are possibilities of the TFCC injury, and ganglion cyst is also common at this area. So a joint arthritis. First carpometacarpal joint is mostly a degenerative arthritis. It is affected more commonly in degenerative arthritis, whereas the inflammatory arthritis can cause inflammation in any of the other joints as well. So here it is in between the trapezium and the first metacarpal joint. So if we have to inject, we have to inject at this point. But remember, usually, if the patient is having degenerative arthritis and the patient is not responding with the pharmacological management, then we can go for the injection of the steroid. Usually 5 to 10 milligram of the steroid is good enough for this joint, but definitely for aged patients, it gives a very good pain relief. And while assessing joints like a radius, this joint between the scaphoid and the radius, here we have to always try to put the hand in such a way so that we can access the joint more easily. Now coming to the bone erosions. What are the disorders? It is mostly the rheumatologic disorders, or in case of psoriasis, this type of rheumatoid arthritis, spondyloarthropathy, psoriasis that can give rise to this type of joints. So the bone and the soft tissue, the linear or the clean mark, what we have seen, that might be hampered, like a osteophyte could be formed, like erosions, margin erosions could be possible, or like this. Okay, see, these are like the cavities, they are also formed. Okay, so these are the possibilities that might occur in case of a inflammatory arthritis. So if you are getting these findings, we can think of that. Okay, so there are multiple intracarpal joints. So fluid accumulation, inflammation, they are possible in these areas. Then there is the distal radio-ulnar joint. This I have already demonstrated. So in case of inflammatory arthritis, there could be fluid at this joint, and we have to inject in the same way. Okay, so you can see this is the needle and this is the steroid injection at the distal radio-ulnar joint. And this is quite common, especially for the rheumatoid arthritis when the patient is not responding, okay, with the pharmacological management. Usually we give an injectable steroid like 40 to 80 milligram at the beginning, and then we start with the DMARDs and then we try to expect this will go. But when all the joints, even the CRPs came to normal, but still in 1-2 joints inflammation is remaining, we usually go for the intra-articular injection. This is the ganglion cyst, usually occurs from the tendons, and there is a fluid within the ganglion. Sometimes it is very recurring, and one of the very easy management is just inject a very thick needle. Don't inject a thin needle. You will not be able to draw the thick fluid. You should take at least 18 or 16 gauge needle and put it inside, and then aspirate and inject a small amount of steroid. This is a very common therapy for this disorder. Okay. Then there could be associated tenosynovitis along with the arthritis. There could be possible fluid in these joints, and in acute condition, in acute tenosynovitis and arthritis, there could be possibility that it may take color in such a fashion. Then we have the pains in the, here the pain is for the, can anyone tell which type of disorder causing this pain?
Quervain state.
Yes, Quervain. And this type of
intersection.
Proximal intersection, yes. So here we have to, here it will be inflamed. We have not seen that much of fluid in the normal volunteer, but here you can see sort of fluid. So you have to do not go inside the tendon, just come within the sheath, and within this you inject the fluid. Okay. So it is the Quervain tenosynovitis. Again, here you can see the thickness has been increased. Here also there is active, you can see this hyperemia. And this is the Frankelstein state. Very simple. Just put the hand like this, close the finger and put it like this. Okay, and everyone is able to see my hand as well, I think. So if there is pain, it is not necessary every time you should close the thumb fingers, but even if you just put it like this and then do the some ulnar deviation, we will be able to see pain reproducing at this point. Then in case of proximal intersection syndrome, there will be inflammation at this point. We have discussed, and there will be some swelling. Here I have a video, small video of a patient as well. There also will be seeing how it looks in a patient. And here we have to inject at the junction. The injection video also having in the video section. So you'll be able to see that. Distal intersection syndrome, similar, but happens slightly distal to the styloid, and the treatment is the same at the level of the distal intersection. Then there are extensor tendinitis. Here we are mostly seeing in the extensor digitorum and extensor indicis. You can see the hyperemia as well. Then we can go for the intervention. They are almost similar. You have to locate the area. Similarly, this is the inflammation at the ECU, extensor carpi ulnaris. So I have told you in digitorum and extensor carpi ulnaris, it is quite common. In ECU also I have given injection, but sometimes we get an isolated ECU tenosynovitis. In those patients, you should always check for the inflammatory markers and the markers for the inflammatory arthritis, because in some patients it could be an initial presentation of that disorder. So even though if I have done the procedure, but if you have not assessed the patient properly, sometimes it might happen that you have done the procedure, but the pain is persisting because of the disease. So when it is known you are doing the DMARD therapy and then you are doing it for reducing it, then it is easy for you to explain why it has been failed, or it is easy that we have tried with the drugs and it is not working. But do not diagnose in first hand that these are the simple or isolated disorders, and then you do the procedure and then you further investigate. Okay, so always do the investigation first and then check for this. Okay, there could be possibility of the issue tendon subluxation from the bony groove, so that can be seen here, and that can cause pain here as well. Then we have the scaphoid fracture, so there could be possibility of the scaphoid fracture as well. Okay, so we have to look for the bony margin. Then scaphoid shift test, or it is also known as the Watson test, that during the presentation I have also described. So basically you have to do this and this, press over the scaphoid, then move it here and this, and then leave it. Okay, so if there is instability, then there could be possible cleft. So it is particularly influential in diagnosing the scaphoid instability. Then TFCC injury. So there is quite possible that this TFCC could be injured. Okay, so we have the extensor carpi ulnaris, and in between the triquetrum and ulna we have the TFCC, and TFCC injury might happen. So there will be a development of a crack like this. Okay. Then we have the ligament injuries. As I have already demonstrated, these small ligaments can undergo injury. It is not only these two ligaments, but others can also go injury. But the chances or probability of these two ligaments are quite common. So here we can go for the PRP injection, and if there is acute inflammation, we can go for the steroid injection as well. The Wartenberg syndrome or chiralgia paresthetica, this is basically a compression of the superficial branch of the radial nerve, and here we can actually see which area will actually be numbed, and there is also neuropathic pain at this point. Okay, so there is possibility of the superficial radial nerve entrapment as well. But usually it is mostly secondary to other occasions, that is compressing over the nerve rather than the solitary entrapment. Now coming to the video sessions, this is one of the video done by Dr. Chinmay Roy, where there is a neuroma here. Okay, and that is actually causing this chiralgia paresthetica. So to diagnosing it, he is injecting a small amount of local anesthetic to check whether the pain is relieving or not. So this is another video. Welcome to the Asian Pain Academy. Today I will be describing. So I'm not going into the theoretical part because this video is already there in Asian Pain Academy YouTube channel. So you can check there as well. I'm just showing the important part is that see the hand. Okay. Just I could give it a better picture or not. Okay, I'm just showing it. So first of all, you can note a swelling at this point, okay, and which is unlike from a location where the dequervance occurs. It is slightly proximal, and here we can see just below this swelling, it is actually moving, and we can see this hypoechoic areas as well. Condition. Remember, in all the places, it will not be a very much fluid because that much fluid not always present. The compartment 2, and there we have the listus tubercle. Then we have the after the listus tubercle, we have the compartment. This is the compartment 3. These are the dorsal compartments. Here you can see this. So this video you check from the website because time is limited. I am not going further, but I am going directly to the injection portion. So side of the proximal we are going in between the tendons. So we have under the ultrasound, we have focused our needle and we have cast the needle at the intersection point and we injected 20 milligrams. Okay, and don't go much inside the tendon because there is a possibility that you might inject inside, and if you are injecting steroid, the steroid might go inside. So be close to that area. And steroid is very powerful thing, so it usually takes care even if you give slightly by the lateral side also. So I think that more or less concludes today. Okay, no more slides. Okay, so any questions?